We started with this slide presentation. It was made almost about 8 years ago for a class. So the whole thing is about bronchic phases. And the meaning of bronchic phases is it's a dilatation of the bronchi. It affects bronchi which are more than 2 millimeters, belonging to the fifth to the ninth generation of tracheobronchial tree. You must be knowing that the tracheobronchial tree is classified by Weibel, starting from the trachea. We are dividing into the two lobar bronchi, then the lobar bronchi dividing into segments, lobe, upper lobe, middle lobe, and lower lobe bronchi, becoming narrower and narrower. So the bronchiectasis affects the bronchi of sizes more than 2 millimeters. It is defined as an abnormal permanent dilatation. Once it gets dilated, it can go back to the normal size. And the bronchial wall also gets destroyed. And based on the shape, it is classified into the cylindrical, fusiform, and saccular types. You can see the picture there. It can be classified as congenital as well as acquired. It occurs as a congenital condition where there is a ciliary dysfunction, like in Tata Gena syndrome or West syndrome, or there may be a primary hypogammaglobulinemia, cystic fibrosis. It's a connective tissue disorder, inflammatory bowel disorder, Hartmann syndrome, or Ehlers. Whereas acquired causes pneumonia due to whooping cough, measles, or pulmonary tuberculosis. These infections usually produce this problem. Or inhaled foreign body in childhood, a patient who had an altered consciousness due to stroke or alcohol intoxication, or general anesthesia procedure where some mild aspiration would have taken place, or dental extraction procedures where aspiration occurs, or cancer of the nose. These are all the conditions where mild clinically instituted and aspiration occurs. The aspirate material goes and lodges in the bronchi of the smaller size that we described. And so when you take a history for bronchiectasis, these possibilities should be questioned. That should be included. And that was missed in the presentation last class that was made. And bronchial obstruction due to tumors or nodes in TB and asparagus infection complicating Roma is also an important contributor. And immunodeficiency states like HIV, chronic lymphoid leukemia, and necrotic syndrome also lead to that. Or toxic insults because of aspiration and use toxic gases and chemicals can do that. And pathophysiology is an inflammation which causes the destructive changes in the walls of the bronchi, and it occurs at the segmental or third segmental level. And bronchial and peribronchial inflammation happens, then the inflammation is by fibrosis. There is also ulceration of the bronchial wall, chronic metaplasia, mucus gland hyperplasia, which is the main reason for the productive cough that happens because of the and the pulse secretions that happen all is because of the mucus gland. And bronchial neovascularization with hypertrophy osteosis of the bronchial sac. The clinical features reduces chronic cough with stupor production more during change of posture. This is a very important but abnormal feature of bronchiectasis. The patient will typically say that when I get up from left posture, I get more cough, or when I turn from right to left side, then I get a violent cough and I have to sit up and eliminate all the secretions. So this change of posture producing a violent cough is a very characteristic feature, and they always have a halitosis or foul smelling breath because of the infection, and because of the increased neovascularization, some of them the new vessels do not have the strength of the original vessels, so they rupture, and patient may come with a history of hemoptysis as a primary complaint. And because of the chronic infection, they may have fever, malaise, thoughts. And when you examine the patient may look pathetic, inefficient, and they have, when you examine the chest, they may have four sluggery rolls. This is a very characteristic feature. And it is due to bronchial obstruction also may be there. Difficult clubbing because this is an infective organ or a it's a suppurative disorder. It comes under the classification of suppurative disorders of the lung. So, digital clubbing is a very important feature. There may be features of lung collapse or consolidation. And complications that can happen in bronchiectasis are massive hemoptysis, and the infection can spread through the blood to the brain also. And being a chronic condition, it can produce amyloidosis, which can lead to amyloid deposit in the kidney, necrotic syndrome. And it may also lead to pulmonary because of the increase in the pulmonary vasculature pressure. And it may have emphysema and pneumothorax. And investigations, collection of sputum for 24 hours produces the classical three-layered sputum. So you can see the upper foamy layer, middle serous layer, and the sedimentary layer, which contains all the cellular elements. And this collection also helps to find out the total quantity of sputum secreted per day. And our aim in pre-op preparation of this patient is to reduce the total amount to less than 30 ml per day. And the investigations that we have to do are sputum culture and sensitivity, treatment with appropriate antibiotic. X-ray may show ring shadows, crack lines, and appearance detected in your OSCE or in the radar. And it may require a high resolution CT scan and QT for reversible obstruction. Bronchoscopic aspiration if the collections are huge, and saccharine test to assess the associated function also in cases of cardiac syndrome is indicated. Cystic fibrosis phenotyping in upper lobe bronchiectasis is indicated. So you may find these are the signs in the X-ray that you may see, or the honeycomb size in the fusiform or calcular aneurysm and the bronchiectasis. You will see this sort of thing. And this is a CT scan which shows a varicose-like bronchiectasis and cylindrical bronchiectasis type marked by the arrow there, and it can have saccular or cystic bronchiectasis. Initial treatment or optimization is used to clear the mucus secretion from the affected parts of the lung, achieved by antibiotic therapy based on the culture intensity, and chest physiotherapy and postural drainage according to the lobe involved is a very important way of preparation and therapy. Then use bronchodilator therapy, even though this is a mechanical obstruction, some amount of bronchodilation may help. Mucolytics to help the use of the secretions. Proper the lack of nutrition should be corrected before surgery, so that patient can withstand emergency surgery to be. And this picture shows the cyclical events that happen. The patients have acute or chronic bacterial infection that may lead to persistent inflammation, that may lead to impaired mucosal clearance. So if this pathology is understood, we can treat the infection by antibiotic, and we can do airway clearance by mucolytic agents. Antibiotics and immunoglobulin primary will be treated, and we can use anti-inflammatory drugs. When all medical and conservative management fail, you have to remove the infected lobe. Basically, we will do the two treatment process. So for that, we have two scoring systems to assess the severity. Bronchiectasis severity index, which has all these features which are used in your condition. There is a BSI that was developed specifically to predict the mortality and hospital admissions and also the quality of life afterward. So these are the parameters that have to be taken into consideration. Age, DNA, hospital admission within last 2 years, number of exaggerations, NRC breathlessness scale, and infection present, colonization, radiological severity. All these things are taken. Then there is another scoring system called PACE score. It's an acronym. FEV1, age, colonization with aeruginosa, and the extension of radiological bronchiectasis and dyspnea. So the PACE score predicts mortality but has not performed well as a predictor of morbidity. So these two scoring systems are used, and the key of optimization that we have to do is first check the cardiopulmonary reserve. Apart from the general assessment of nutrition, control of nutrition, you must do a cardiopulmonary reserve testing. And all patients having pulmonary resection should have a pre-operative assessment in three areas, which is called the three-leg tool assessment: lung mechanical function and parenchymal function, cardiopulmonary reserve. And the most valid single test is the predicted postoperative FEV1. So this one gives about the for any support or the final result what will happen. That can be calculated by post-op predicted post-op FEV1 is equal to preoperative FEV1 multiplied by 1 minus percentage of functional lung tissue removed divided by 100. So patient with a PM for predicted post-operative value of more than 40% had no post-pulmonary complications. And major respiratory complications were only seen in groups of patients who had less than 40% of the predicted post-operative FEV1 score. And less than 30% required post-operative mechanical ventilation. So this calculation helps in assessing the management post-operative. And treatment continuing, patients who do not show improvement with respiratory or have severe hemoptysis or recurrent pneumonia, these are the indications for surgery. And mostly single lobe involvement will require lobectomy. And but if the lesion affects the entire lung on the outside, then but usually it affects only the right or left lower lobe, so it will involve the local resulting only for lobectomy. And when surgery is indicated, then the patient needs to be evaluated by the three-leg stool, which we showed in the earlier slide, the three components. And the three-leg stool assesses the respiratory mechanics, cardiopulmonary reserve, and lung function. And based on that, we have this calculation which I showed. To write as a slide rather than sentences in the exam. This is the reason for this slide. The lung segments, how many segments are there now? So totally there are 42 segments included in both the lungs. Out of these 42, how many segments you are planning to remove? For example, if you are going to remove the right lobe, you will be removing 12 segments. On the contrary, if you are removing the right middle lobe, it will be removing only 4 segments. So based on that, you can calculate the post-op outcome. And patient's ability to effort tolerance is also very important. So this one net, what is the definition that is given? People should be knowing about it. And then the Ask the risk score with regard to cardiac status. The disease revised cardiac index should also be used to assess the cardiac index in these pictures. And the routine lung function test most important is the FEV1, which tells about the ability to expel the gases in the first second. You can do a quantitative lung scan also, and based on that, again, all these points are already shown. And the exercise is testing to assess the oxygen consumption. If the minimal capacity is there, if it is there, you can go ahead straight away with the surgery. If oxygen consumption is less than 50 ml, consider other options. And the indications for surgical resection are persistent symptoms or despite the year of treatment, frequent exacerbations that are quite severe, and recurrent refractory hemoptysis includes the obstructive bronchiectasis into some tumors that also will respond very well. This picture I am showing because the examiners sometimes ask you how to drain the various lobes of the lung or the segments of the lung. For example, upper lobe, middle lobe, right? The upper and lower lobe, right? So this question is sometimes asked, so you must know when to keep the patient upright, when to keep the patient posture, when to keep the patient in like head down position, or prone position, semi prone position. All these things are methods to drain the various lobes of the lung. This is asked in the you can nowadays we have handheld portable spirometers are available to assess the so instead of asking the patient to go to the pulmonology lab to assess all the symptoms, website functions are we can assess this in the website itself. And after evaluation and satisfaction, patient must be optimized using the scope of supplemental line of like antibiotic, test tube, hospital drainage, component. And lung isolation may be required. It's a risk of soiling of the normal lung. This is another component of the discussion on bronchiectasis if cases are given in the exam. So usually if do one lung ventilation, the WMN in the bronchiectasis, and all the questions on the indications for usually it is done through earlier it was done through open thoracotomy for lung resection, in the lateral ventricular position. And once the patient is anesthetized in position, we can ask you about the head to toe survey of the patient. So starting from the head, the pressure points, the possibility of nerve compression, and the possibility of pressure shows developing long duration. All these things have to be taken care of. So the head you have to take care of the eye and make sure the cervical spine is in line with the thoracic spine. Dependent arm should be any compression or overstretching should be avoided, and avoid pressure on the dependent legs and the injury to carry. Don't flex the non-dependent leg too much to avoid sciatic nerve injury. Adequate pattern to all bony parts. And anesthesia management for lobectomy and slightly different. Free of orders, NCO as per guidelines, avoid sedatives and narcotics if the patient has a compromised respiratory function. Drop, come to the monitor, you require a ABG, and ABG sampling has to be done frequently. So, the line is indicated. Then pre-oxygenate the patient. Use a wide bore IV line, then non-dependent lung. That is the limb which will not be on the which will be on the operative side. That will become the non-dependent lung. And the internus, the induction is propofol as usual. The thoracic epidural measured at 390 in space will help in not only intra but post-op analgesia. And you can use petronium as a relaxant or tractarium and cisatractarium. And but if cisatractarium and atractarium better to use it as an infusion rather than intermittent bolus doses. And placement of tube or a WNT as discussed with the surgeon or as indicated, and you can maintain with air, oxygen, and the volatile oxygen and control ventilation. Fluids and blood to maintain adequate volume using warming devices. Post-op reversal and expedition based on the pre-op calculation of the post-op retrieval one. So as we discussed, it could have given an idea, the plan for elective ventilation or extubation on the table depending upon the nature of the surgery. And monitoring, oxygenation monitoring, PaO2 measurement is very useful. The SpO2 specifically during lung ventilation is very important. And the patient who has a PO2 of 400 millimeter with PO2 is less likely to desaturate than the one who has a PaO2 of 200 millimeter with the same PO2, though both may have SpO2 of 99% to 100%. So, arterial measurement of oxygen tension is very important rather than relying on the SpO2 when you go for lung ventilation. Capnometry, similar to oxygenation, PaO2 values also correlate better than CO2 values, which is non-invasive. And the gradient tends to increase during lung ventilation. And real line CV phase and CEP is considered not reliable in patient useful for post-op monitoring of fluid status. So more than intra, especially when you do a pneumonectomy and remove one lung completely, the pulmonary vasculature volume is reduced. So at that time, CEP becomes very, very important. And PA catheter is very unreliable and also it is likely to be damaged when it involves the entire lung. And indicated only in patients associated with cardiac or renal diseases and may be damaged during clamping of the pulmonary artery, as I said. And transesophageal echo is very useful as a routine monitoring, especially if the myocardial function is compromised. It also helps in qualitative assessment of the right ventricular function, especially in pneumonectomy cases. Post-op analgesia and thoracotomy pain, we have already discussed in the earlier class with the condition. So it can be treated with intercostal nerves, caused by intercostal nerve incision, and intercostal nerves ICD also produces the pain. Mediastinal cranial nerves, cranial nerve 10 also important. Central diaphragmatic pleura C3 to C5, ipsilateral shoulder breakage like this. So all these things are the positive factors for thoracotomy pain. So there is no single analysis to provide full relief except multimodal techniques are used. In post-op analgesia, you can include opioids, anti-inflammatory agents, and local anesthesia. Systemic opioids can be done by PCA, CADs, or opioid sparing effect. Keeping low dose infusion, dexmedetomidine, combined with LA now blocks the costly interpleural thoracic epidural related. A few words about lung isolation. Indicated can be classified as absolute and relative, and presently classified as lung isolation and separation. The absolute indications to promote normal lung from soiling from the disease spot, like the bronchiectasis, lung abscess, pneumochlorosis, and pulmonary hemorrhage. Relative, mostly for surgical exposure. So, we asked by the cardiac or thoracic surgeons or mediastinal features, vascular aneurysms, especially aortic arch aneurysms, esophageal surgery, and some orthopedic surgery involved in the thoracic spine, like port spine, etc. So that is mostly because of the surgical exposure requirement. And the newer recommendation for differential pattern of ventilation in cases of unilateral reperfusion injury, the lung transplant, pulmonary thromboendarterectomy, unilateral lung trauma, etc. And lung isolation can be achieved by the use of ULPs, bronchial blockers, or a single lumen. So these are the three methods for lung isolation. And lung isolation can be achieved with a lung bronchial tubes also. And double lumen tube commonly used method for lung isolation. We usually use prefer left lung and the bronchial tube because of the increased length of the left main bronchus. And bronchial blockers are used with a standard endotracheal tube contained within the separate channel inside a modified single lumen tube. Single lumen tube is the standard EP tube which advanced into one bronchus isolates the other one, rarely used except in cases of difficult area and emergencies. And the advantage, these are all pictures of the double lumen tube. Advantages, you can ventilate as well as aspirate each lung independently. And commonly used separate ones for right and left sides are available. And in exam, they will show this tube and ask you to identify whether it's the right side or left side. And the tube has been taught that right side the endobronchial tube has a shorter length opening for the upper lobe bronchus. Is close to the dual, whereas the left lung, the bronchial tube, is a longer length and doesn't have that opening for upper lung bronchus. So bronchial blockers usually insulate the diseased lung. You cannot ventilate that side, and the older method is not used nowadays. The bronchial blocker was a early method. They tried to simply separate the lung, not use it for any isolation purposes. And you can use a single lumen tube, which is a larger compared to your regular older technique before they developed a double lumen tube. Can ventilate healthy lung only. Techniques of prevention of hypoxemia is another common question they ask you during one lung ventilation. Ensure correct placement of the tube is a very, very important fundamental step. In cases of gradual desaturation, increase FiO2 to 100%. If not improving, add 10 centimeter tube to the ventilated lung or add CPAP to the dependent lung, which is not ventilated. If chest has been opened, ask surgeon to flap the pulmonary arteries and the lung to be removed. If saturation continues, the patient becomes hypoxemic. Abandon one lung ventilation and switch to two lung ventilation. These are the common 6 steps which you have to remember and reproduce your exam. Post-op complications following respiratory failure, which may require supportive ventilation. Atelectasis, which require a bronchoscopic examination to remove any obstruction in the ventilation. Pneumothorax, because of the blocked ICD, or there may be a stump fracture, which may cause a bronchopleural cyst and cardiac herniation, which is may require an emergency exploration, especially in the and hemorrhage may be quarantine with reopening or arrest of bleeding. Arrhythmias, especially in like abnormalities, require a BPRM also. And bronchial disruptions, tongue blowout, emergency correction, right heart failure, when impaired lung is removed, the load on the pulmonary vasculature increases, which may produce the right heart pain failure. That may require IPPV, dobutamine, hydroquinone, and nitric oxide. So, earlier open procedure was the thing to do any lung surgery, but now video assisted thoracoscopy has come. But the precision that is required is challenging in these cases, like the jackknife position or the classical position. The same because the CO2 insufflation will be done Carbon dioxide monitoring becomes very, very important in these patients. And these are the codes that are normally made. Yes. So the decisions and codes and how these instruments are used. The middle coat is usually placed through the 7th or 8th space, and the anterior coats are usually placed near the respective axillary lines, anterior axillary line or posterior axillary line. And this may be sometimes, if not successful by video assisted, they may plan to open also. So these incisions will be, or the holes will be made accordingly so that we converted into open compartment at any time. These are the benefits of video assisted: reduced acute pain, reduced use of intravenous narcotics, reduced need for epidural catheter, reduced length of hospitalization, reduced time to return to regular activities, reduced impact on immune system, and reduced overall cost. So, and the less blood loss, rescue brain duration less, short term to peace better, and so these are all the intraoperative advantages. Sometimes this is done for esophageal and spine surgeries also. So just closest to all the points that required to be known. You can make it concise. If it is asked as a theory question discussion, you can pick out the required points from this, and you can arrange them in order so that you can present them using your. Okay.